Have you been diagnosed with a condition called lumbar spinal stenosis? Or maybe have pain in your back that travels down your legs that's worse when you stand for a period of time or walk? Well, this could be lumbar spinal stenosis. My name's Anthony Ghosh. I'm a consultant spinal neurosurgeon and founder of the Spine MDT. In this video, I'm going to discuss the non-surgical treatments of lumbar spinal stenosis, but if you hang around to the end of the video, I'm then going to talk about when to consider surgery. I give an overview of lumbar spinal stenosis with all of its treatment options in another video that you can check out below. This video is going to focus on the non-surgical treatments. So that the treatments make sense, let me briefly explain what stenosis is, or spinal stenosis. Let's quickly look at the anatomy. The spine is made up of a stack of bones called vertebrae that start deep in the pelvis and make their way up all the way to the skull. You have 5 of these bones in the lower back, the lumbar region, 12 in the thoracic spine, the bit that's braced by your rib cage, and then 7 in the neck. If we zoom in a bit, each bone is a large cylindrical block of bone with an arch of bone at the back, and if you stack these up on top of each other, you form a tunnel through the middle. In that tunnel runs the spinal cord, which is the main bit of tissue that transmits messages between the brain and the body. The spinal cord terminates roughly around here, just at the top end of the lumbar spine, and off the bottom of the spinal cord are the spinal nerves that run down. Stenosis is when there is narrowing, it's a Greek word for narrowing, of the canal, the tunnel through which the nerves run through. And this is usually focal and is caused by a combination of problems. Wear and tear over the years with age can cause thickening of the ligaments, some of the bones, the facets, the joints around the spine, as well as minor bulges from dried up worn discs. A combination of all of the above can cause focal narrowing in different areas, putting tightness or a bit of compression on the nerves. And classically, patients complain of pain when they walk or when they stand for a period of time that radiates down the legs because of the fatigue in the nerves. And this tends to improve when patients rest, or sometimes, interestingly, when they lean forwards. And that's because when you lean forwards, these ligaments here at the back stretch out a little bit, creating more room here in the canal. So let's go through the non-surgical treatments. I break it down into 3 modalities: specific exercise therapy, mechanical manipulation or manual therapy, and then there are pain interventions. For the first 2 modalities, I normally work with a physiotherapist or osteopath, but some chiropractors as well. Let's go through them. If the stenosis, according to your scan, is mostly caused by the thickening of the ligaments at the back, then the exercise therapy will involve a group of stretches and exercises that stretch out this ligament in the hope that over time it just thins out enough to give the nerves a little bit of leeway. One example is this forward stretch where you can see here the bend is from the top down. So imagine peeling your head and your back off of a wall from the top down to stretch out the ligaments at the back. Now let's talk about mechanical manipulation or manual therapy. If we go back to our diagram here, when we review your MRI scan, if we feel that most of the stenosis is actually caused by bulging of the disc as opposed to the thickening of the ligaments at the back, then various manipulations we can do that apply traction. Imagine manipulations where we can pull these 2 bones apart a little bit to create a bit of a vacuum and suck some of this disc back over time. That can also create some space around these nerves. Often that can be done by hand, but there are new technologies, one specific one called intervertebral differential dynamic therapy, a kind of traction table that you lie on, get strapped in, and then it applies traction to the very specific level that we want the traction applied, and this can be quite effective. Then there is pain management, which is a combination of a review of your medication and painkillers, to see if that's helping you get through the pain at least, so you can get through day-to-day activity. And then there are the actual invasive pain interventions, such as injections to the spine, caudal epidurals perhaps. This is where a needle is passed through the skin of the lower back and directed to inside the spinal canal with x-ray guidance, and a mixture of steroid and local anaesthetic is injected. This is often done by a pain specialist, but some surgeons also do the injections. In a multidisciplinary setting, we try and use the skills of all the different individuals that look after spines. This is why a thorough assessment, clinical examination, and a good history is really important, as well as a really thorough review of your MRI scan to help decide which is the best treatment modality to get the best result here. Often, in my experience, I find it's usually a combination of things, and sometimes we need a combination of the above treatments. Now let's talk about when to consider surgery. Often it's if the above measures have all failed and the stenosis on the MRI scan is so severe as shown on this scan that there's literally no space around the nerves whatsoever. It becomes unlikely that continuing with the interventions mentioned above is actually going to make a difference. If you have either developed weakness in your legs, or you have difficulty passing urine, problems with your bladder or bowel, or control of your bladder, then I would recommend surgery, and sometimes urgently, to try and protect the function of those nerves and recover some of that function. I really hope you found this video helpful. If so, please click that like button and subscribe to the channel. Also visit us at spinemdt.com to see how we can help you. Thank you for watching.